we thought we'd do this webinar because scheduling time to travel or to visit the workshop is sometimes hard or sometimes expensive. It looks like a few of you have done maggot therapy already, but some have not. So I will try and gear the talk so that it best meets the needs of everybody. We usually offer CME with our presentation partners if they're accredited. We don't have a presentation partner this time, and so there is no CME. However, I still feel that it's appropriate to disclose my potential conflicts of interest. I am on the board of directors of the BTER Foundation, and therefore have written much of the lecture slides that we'll go through today. I am also co-founder and laboratory director of Monarch Labs, which produces the Medical Maggots brand of medicinal maggots. This is a break-off of my university research laboratory when it came under FDA regulations in 2004. Finally, I am a staff physician for the Orange County Health Department in the HIV clinic and do consulting for pharmaceutical manufacturers of HIV pharmaceuticals. Well, you didn't come here to listen to me talk about myself. You came or tuned in because we have a serious problem. And that problem begins with chronic wounds. Wounds have been actually increasing over the past several decades. They were brought down by antibiotics and new surgical techniques in the 1940s, but have been increasing probably largely because of the ability to keep people alive with various illnesses, paralyzing illnesses, deteriorating medical illnesses, which used to shorten their lives. Now we're living longer. We're living, some of us, in intensive care units and getting pressure ulcers, diabetic foot ulcers, and so forth. In addition, antimicrobial resistance is increasing. And on top of that, with healthcare costs rising and consequently inadequate staffing to meet our needs, we have some serious difficulties in reaching all the wound care needs that are around. Now, there are solutions, many solutions, in fact, for wound care, and that's a good thing. The more solutions you have, the better you are able to pick the right one for the individual patient or the individual wound. So what we're going to talk about today is one specific wound tool that, if you have it in your toolkit, you can pull it up when you need it for that appropriate patient. And that one is maggot therapy. So I think a set of objectives that's appropriate for today's webinar are that by the end of the hour, you should be able to list some clinical indications for maggot therapy as well as relative contraindications. In addition, I'd like you to know the biology and natural history well enough so that you can not only describe the metamorphosis, but explain how it affects the clinical application of maggot therapy. To reach these objectives, we'll talk about the history and current status of maggot therapy, and then we will review the literature and clinical data that supports it. Finally, we'll discuss maggot biology, and then take some questions. Now, the value of maggots in wounds has been documented by military surgeons for centuries. In fact, it was a military surgeon from World War I who probably first introduced maggots intentionally into wounds. This was Dr. William Baer at Johns Hopkins, and Baer presented his findings treating osteomyelitis or bone infection in children in 1929. He later published those in 1931. Maggot therapy at that time took off quite rapidly and successfully, and within just a few years, over 1,000 surgeons were using maggot therapy in the United States and many more in Canada and Europe. In fact, the pharmaceutical company Letterly Laboratories produced and distributed maggots for those hospitals that did not have their own insectaries and produced their own supply. Well, maggot therapy decreased rapidly, not rapidly, but dramatically in the 1940s. This was probably due to the improved wound care techniques that came out of World War II, along with the antibiotics that now began to come to market. In fact, the antibiotics probably played a major role by decreasing the types of infections that were being treated with maggot therapy. Many of the bone infections and soft tissue infections were actually spread from trauma or upper respiratory infections or other infections that had become bacteremic and then spread, forming abscesses. But this was not happening so much with the advent of antibiotics, and these sorts of wounds decreased dramatically. There were a few sporadic reports of maggot therapy used as a last resort during the 70s and 80s. And by 1990, we started to ask ourselves, why use maggot therapy as a last resort and proclaim it to be so good, so effective, and not use it earlier? How did it compare to other treatments? Should it even be a last resort or another treatment? We have to do some clinical trials, some prospective clinical trials. They had never been done. So they were done in the 1990s, and subsequently there have been several prospective studies, retrospective case-controlled studies, and other controlled investigations. Again, rapidly, it became popular once the results were published. In 1995, physicians around the world started using maggot therapy again. By 1996, you had the founding of the International BioTherapy Society, and the Better Foundation itself was founded in 2003. Moving on to 2003 and 4, the FDA began regulating medicinal maggots, and in January of 2004, the first brand of medicinal maggots was given marketing clearance. This was, in fact, the first live organism ever to be given marketing clearance by the FDA. There are now 2 such organisms used therapeutically. The second is leeches, and leeches were granted marketing clearance 6 months later. Moving up to recent times, last year it is estimated that 25 laboratories worldwide were producing medical-grade maggots, and they sent out over 50,000 treatments to patients in over 30 countries. That is a very rapid rise for a medical product, especially, well, we're talking about maggots after all. So why is that? Why were people readopting maggot therapy? I point to 4 major reasons, I think. First, chronic wounds, as we said, is still a major problem. It's estimated that last year there were about 100,000 amputations, mostly from diabetic foot ulcers that failed to heal. We all know the tremendous cost of pressure ulcers to the patients themselves as well as the healthcare systems that treat them and cope with them. In addition, antimicrobial resistance is on the rise, making infections and wounds much more difficult to treat. clinical studies are now available that demonstrate clearly the efficacy and safety of maggot therapy. But one of the most influential factors, I believe, is people's own personal successes. You know, many people, myself included, have come to maggot therapy initially because of a wound that failed everything else. A wound like this that was to be amputated. We use maggot therapy as a last resort. It may or may not heal the wound. After all, many of these wounds have no blood supply. It's very unlikely that they will heal. That's why patients are recommended to have an amputation. So to expect maggots or any treatment at that point to heal the wound is a bit much to expect. Yet, in published cases for maggot therapy, 40 to 50% of such cases actually did heal. The amputations were avoided. This is just for maggot therapy being used as a last resort prior to amputation. That was certainly the case in this man's history, a diabetic gentleman with toes falling off for about 9 months. He refused amputation despite having no pulses in his foot. He came to me for maggot therapy. I told him he needed an amputation, and the maggots would simply dissolve the necrotic and ischemic tissue, and he'd have bones left. He'd have to get an amputation. He asked me to prove it, and I attempted to do so. And although his big toe did continue to necrose and was then amputated, the rest of his foot healed well, and he walked out of the hospital. This is a photograph 1 year later. This is a gentleman here that had his wounds, both feet, for 3 years, receiving weekly or biweekly podiatric and orthopedic surgical care and debridement. He saw me being pressed to get an amputation again, and we went ahead per his wishes and attempted to debride this with maggot therapy. One cycle, or 3 days later, you see his foot and wound at the bottom picture. The wound looks much larger, but is now clean, and indeed went on to heal. So you can see now I'm feeling a little bit more comfortable with the results of the therapy. And many people, even if the maggots don't prevent the amputation, they can see the effective debridement. They can see what's really involved in doing the therapy. It's relatively easy, and they recognize that they don't need to save this for their 40th treatment. They can use it as their 4th treatment option, rather than waiting 6 months or a year of treating the wound unsuccessfully. So this gentleman was in the hospital for 3 weeks receiving antibiotics, not responding. We went ahead and did his treatment. This would be my 3rd patient ever. And 3 weeks later, you can see a clean wound bed after that. Another gentleman who was not a surgical candidate because he had just suffered a myocardial infarction. A young man paralyzed, so he didn't feel the adrenergic drugs infusing out of the veins in the pretibial region where his IV was. His knee would be about here at that red dot, his ankle about here. So this is a fairly large pretibial wound. We left the eschar as it is, even though eschar, being dry, takes a little bit longer for the maggots to completely dissolve. But this was a study and a study patient, and so we left the eschar as it was. It dissolved. First half fell off. The second half fell off on the next treatment cycle, and pretty soon his wound bed filled with granulation tissue enough to support a split-thickness skin graft. 2 more patients only. This gentleman with an ischial wound, pressure ulcer, from his wheelchair. Rectum is over here, ischium over here. He developed callus, his skin broke down, he was hospitalized for a couple weeks, and it was recommended he get another flap. He refused flap, requested maggot therapy to his wound, and we went ahead and did 2 cycles, or 2 cycles spread over just over a week of treatment. And you can see at 10 days, his wound has completely epithelialized. And the last patient I'll show you is a gentleman whose bilateral hip flaps, trochanteric flaps, we had treated with maggots when they broke down. He healed those wounds but had a donor site over the sacrum that remained for many months. He was scheduled for a split-thickness skin graft 4 weeks from when this photograph was taken. He requested that we do maggot therapy, and I told him that the maggots would do nothing for him, for his wound bed is clean, it's got great red granulation tissue. I told him the maggots would just die with nothing to eat. But he insisted, and again, I was studying maggot therapy, so I thought, why not? Let's see what happens. We placed the maggots on the wound, and as you can see here, it began to develop islands of epithelial tissue, which is most unusual for a total thickness wound like this. Furthermore, the scar tissue broke down in 2 places, revealing nylon sutures in abscesses that had been overlooked during surgery. The sutures popped out, the wound resealed, and within 2.5 weeks, his wound was completely epithelialized and healed, and so he did not have to undergo the split-thickness skin graft. So let's look at what the literature says to help explain all of what you and I saw, and explain why, after doing those studies, I continued to use maggot therapy for my clinical patients, not just my study patients. To put the literature into some context, I like to think of the mechanisms of maggot therapy. There are 3 described mechanisms. 3 described mechanisms: debridement, disinfection, and promotion of wound healing. We'll discuss each in a little greater detail. Debridement is the best characterized. For nearly 100 years, people have demonstrated the ability of the secretions from the maggots, which are digestive juices, to dissolve necrotic tissue. Focusing just on the more recent and pivotal studies, let's begin with Lars Visnus and his team at Stanford. During the 1980s, they used experimental rat burn wounds and extracted the secretions from the maggots. The digestive juices were found to contain a whole host of proteolytic enzymes, and when placed on the rat burn wounds, they dissolved the necrotic tissue. Studies of the proteolytic enzymes have continued up until recent times, and a lot of attention is currently being paid to the serine proteases, which, as most of you know, are key elements in the wound healing process. The FDA regulates medicinal maggots as medical devices, not as biologicals, not as drugs, despite their elaboration of enzymes. In part, this is due to their physical action on the wound. They are covered with rows of spicules or spines, plus they have 2 mouth hooks that they use for ambulation. And when the maggots crawl over the wound, they are rubbing against the wound with these rough surfaces, very much like a surgeon's rasper or file. So there is literally a physical debridement going on. We looked at debridement in our studies by plotting the surface area of the necrotic tissue against time in weeks. Now you will see here that the average control patient receiving whatever the wound care surgical team prescribed, be it a dressing, medication, antibiotics, or surgery, the average stayed pretty much constant. Some improved, some deteriorated. There's a range, but the average remained constant. And that is really no surprise because the patients were selected from among non-healing wounds. Those who received the maggot therapy intervention, however, showed a dramatic and by 3 weeks significant decrease in the surface area of necrotic tissue. This plot is for pressure ulcers, but we saw the same thing in diabetic foot ulcers. Again, a rapid decrease in the surface area of necrotic tissue, significantly different from control within 2 weeks. Others, such as Markovich, have repeated this experience with diabetic foot ulcers, and even Dumville's group, published 2 years ago now in the British Medical Journal, saw the same with venous stasis ulcers. In that study, which is the largest to date, a prospective study of venous stasis ulcers treated with maggot therapy versus their control or standard treatment, which was hydrogel, you can see that the median time to debridement with maggots was 14 days compared to 72 days with their control arm. So that's 5 times faster debridement. What about disinfection? Well, again, many people have identified the antimicrobial power of the digestive juices extracted from the maggots. Recently, Costa Mumsoglu in Jerusalem has demonstrated this elegantly. Bernie Greenberg in the 1960s showed the same thing, that bacteria were completely killed by the time they reached the mid-hindgut of the maggot, and the excretions coming out of the maggot had no living microbes. Recently, Ukema in the Netherlands and Cassander and their group showed that the maggot secretions also inhibited biofilm formation and dissolved biofilm that had already developed. They used experimental models with Staph aureus and Pseudomonas biofilm. These are definitely new discoveries in the maggot therapy realm. But what clinical significance does that have? Until recently, there wasn't a lot of clinical data about the antimicrobial effects. That changed with some studies by Jose Contreras Ruiz and Dr. Tariq Tantawi in Alexandria. Jose is in Mexico City. And both of these studies did show that the maggot therapy decreased the number of organisms and the number of species so that you now have some in vivo evidence. Several people, including Dr. Bolton's group here, have looked specifically at antibiotic-resistant bacteria like MRSA and shown also in the test tube and in the patient the maggot therapy was associated with a decrease or eradication of MRSA. Still, we may say, well, what clinical relevance is that in terms of whether the decrease in number of organisms is really important for the patient. David Armstrong addressed that question by recognizing that an impartial, an unbiased assessment of clinical infection could be had by looking at the antibiotic prescribing habits of the primary care physician. So he looked at patients in the long-term care and whether or not their doctors were prescribing antibiotics or stopping the antibiotics, and used that as an assessment of clinical infection. What that group showed was, in fact, that the maggot-treated patients had fewer antibiotic days. Their antibiotics were being stopped earlier. Growth stimulation is, for me, one of the most fascinating aspects of maggot therapy. And there's much less clinical data here. Lots of new data coming in, though. In our own experiments, in our own clinical studies, we tried to assess this growth promotion by looking, for one thing, at the granulation tissue as a percent of wound base over time. In our pressure ulcer patients, then, we saw that the granulation tissue pretty much remained, on average, stagnant for the control group. The maggot-treated patients, however, had a rapid proliferation of granulation tissue. The diabetic foot wounds, similarly, had a significant increase in granulation tissue within just 2 weeks. If you biopsied these wounds getting maggot therapy, you saw angiogenesis. You saw a proliferation of new blood vessels moving into the wound bed. Why is this happening? Well, we did some studies with cell culture, fibroblasts and endothelial cells in particular, and showed that when exposed to maggot secretions, these cells proliferated faster than baseline. Wolina's group in Germany looked at it from a different perspective. They measured tissue oxygenation before and after maggot therapy, and what they discovered is that oxygenation, and therefore you can assume tissue perfusion, went up after maggot therapy. Dr. Pritchard's group in the UK has been studying maggot secretions for many years now, and one of their studies looked at fibroblast migration over a three-dimensional wound model. When exposed to maggot secretions, they observed that the fibroblasts actually migrated from the wound margins freely over the wound faster than did the controls. They hypothesized that this is a result of the proteolytic enzymes that are cleaving some of the proteins that hold or anchor the new cells at the wound margin. You know, wounds heal from the margins through mitosis, through cell proliferation that then covers the wound inwards. But if the cells are able to travel to the center of the wound, then they can now multiply in all directions, not just centrally, but peripherally, and this might be one of the factors that hastens wound healing. Indeed, this may be related to those islands of epithelialization that we saw in our earlier wounds. So, again, you have three mechanisms of action: debridement, disinfection, and the promotion of wound healing going on. Well, we need to talk briefly about maggot biology, because maggot therapy is really the therapeutic or controlled myiasis, maggot infestation. A maggot infestation of a live host is called myiasis, and maggot therapy is using that myiasis with several controls so that it is safe and effective. So we need to remember, firstly, that the fly starts its life as an adult. The adult female lays up to 2,000 eggs, which may hatch in a matter of hours. Depending on temperature, the larvae will grow for 3, 4, 5, 7 days or more. Larval growth and pupation are highly temperature dependent. Once those larvae are satiated, are completely fed, they will instinctively leave the host, looking for a safe place to bury themselves. They'll come to rest, they will pupate, and about 2 weeks later, they will emerge or eclose as full-grown adults. So how do we control this process so that our maggot therapy is safe and effective? Firstly, you want to select a species, and preferably a strain of the species, that's safe and effective. Secondly, you'll want to grow that in a laboratory that minimizes exposure to pathogens and also exposure to unwanted species. Now, the garden variety maggot is converted into a medicinal maggot or medical grade maggot through the process of disinfection, killing the germs. We used to call these medicinal maggots sterile maggots. Sterile really is not a good name because sterile means void of life and the maggots are still living. We now use the term disinfected or germ-free maggots. This is done in order to render the maggots medical grade or germ-free, but you have to check. So another control is the quality control and inspection to ensure that the disinfection procedure was completely effective. We also control the myiasis at the bedside on the patient using special dressings that keep the maggots from migrating or leaving, even if they are satiated, until we, the therapists, are ready to remove them. We'll talk about dressings a little more in a minute, but first we need to say a word or two about the indications and contraindications. Above all, refer to the package inserts. Always read the package insert, which go over this in great detail. There is one brand of medicinal maggots cleared for marketing in the U.S., and they have specific indications. Those are as follows: debriding non-healing necrotic skin and soft tissue wounds, including pressure ulcers, venous stasis ulcers, neuropathic foot ulcers, and non-healing traumatic or post-surgical wounds. This is a relatively broad group of indications, but notably missing is osteomyelitis, which, as you recall, was one of the major treatments during the 1930s and 40s, as well as infection or wound healing. These are not approved clinical indications for the currently licensed brand of maggots, and that is due to the lack of sufficient clinical data at that time to really support an indication for those. So I want to make that quite clear. What are the relative warnings or contraindications? Well, there are several, and again, see the package inserts of whatever brand of maggots you're using. But the major ones I want to focus on here are the ones you're most likely to see, 1% or more. First is pain or discomfort. In published studies, it may range from 5 to 30%, but it always occurs in patients that you can predict will have pain because they have wound pain even before the maggots. Those patients with wound pain at dressing changes, you can anticipate, and you should even warn them, they are likely to feel discomfort or pain when their maggots are large enough to feel crawling over their wounds. That'll be in about 24 hours. I use analgesics liberally in these patients, and I also promise them to remove the dressings if their pain becomes intolerable. This gives them some control, and control always relieves anxiety and always is believed to allow patients to tolerate a little bit more pain because they know they are in control. Anxiety is less common than is commonly believed, but some patients do get a little anxious. We recommend a lot of education, having them view our educational videos or patient interview videos or speaking with patients who have undergone maggot therapy. But patients don't have all that much anxiety because they can put things into perspective. They have a draining, stinking wound. Maybe they are facing amputation or had surgery before. They can put it into perspective a lot better than hospital administrators. Hospital administrators is where we see the majority of anxiety. And the best I can offer, again, is education and some of our courses, our reading materials, our interviews, and maybe some anxiolytics. Lastly, the most common problem that we see is late deliveries. You know, maggots are highly perishable. They should be used within 24 hours of arrival, and that means they are sometimes ordered to arrive the day of the procedure. If there is a snowstorm and the courier cannot deliver the maggots, or if the courier forgets their glasses and delivers to the wrong address or leaves the package back at the station, why, the package is going to be a little late. And 1% of the time, 1.5% of the time, in a study that was done by the Better Foundation and Monarch Labs, what's called a Phase 4 post-marketing study, this was the most common adverse event reported, and occurred 1.5% of the time, a 1 hour to 24-hour late delivery. And that can be a hassle, so you want to plan on that. Well, you know, sometimes maggot therapy does not heal the wound, especially if you're using it pre-amputation or as a last resort. You're likely to see the wound with a bigger hole, maybe cleaner hole, but still a lot of necrotic tissue, no blood flow. That's not going to heal. And a wound like this is going to be referred by me to amputation. I'll give up to 3 treatments with maggot therapy, but no more. After 7 to 10 days or 3 treatments of maggot therapy, if I haven't seen at least some good, healthy wound base, then I'm going to recommend amputation. This is called a failure to respond to maggot therapy. It is not an adverse event. It is a failure. I'm not going to speak a lot about maggot dressings other than to say that they are intended to keep the maggots on the wound, to allow air to reach the maggots through a porous dressing, a net of sorts, and to allow the dissolving necrotic tissue to drain out. They are sometimes made in custom designs, or a pre-manufactured dressing might be used. Some people make them out of nylon stockings or other prefabricated net stocking-like dressings. In Europe, there are containment bags available, but these are not available throughout the world, not available in the U.S. So with that, I'm going to conclude, and then we're going to open it up to some questions. Hopefully you have an understanding now of the clinical indications and contraindications of maggot therapy. You're able to describe the natural history of the maggots and tell how that relates to doing the dressings and maggot therapy, such as the maggot's tendency to wander off the wound when they're satiated, and how we need to keep them bandaged securely until we're ready to take them off. We do have other educational programs. We have workshops where you can actually try your hands at the maggot dressings. We have other materials on our website. In fact, one of the attendees today, Dr. Marcondes, asked us to remind everyone that he has written a book on maggot therapy, which is available in Portuguese. Dr. Fleischman and a team have also written a book in English, German, Japanese, and Korean. And just recently, the Mexican Association for Wound Care and Healing produced a clinical practice guideline, a very nice compendium of maggot therapy in Spanish and English, and this will be on our website within a couple of weeks. So with that, I'm going to invite you all to go ahead and write down your questions. I will read those questions, and maybe while I am reading the questions, you can go ahead for me and fill out a little bit of this survey, giving us some feedback on whether or not this webinar has thus far met your needs. So while you all continue to fill out the survey, I'm going to read through some questions. I see here, how long do the maggots stay in the wound? Sorry, I didn't discuss this in detail. 2 to 3 days. I recommend 48 hours only for most wounds because that's sufficient time for about 50% of the maggots to be mature. And at least if it's your first or second time doing the treatment, these maggots that are mature will spend the next 24 hours trying to get out of the wound. So it has to be very, very secure in order to last for 3 days. So I recommend starting out with just 2 days. That's enough. You don't have to squeeze out the last bit of work from the last maggot. Maggot therapy works well in the hospital setting. Is there some guidelines for home setting use? Yes, maggot therapy can be used in outpatient clinics, at home, in hospice, in the nursing home. The Better Foundation has produced some policy templates that can be found on the website, or you can email me for those. They can be modified for home care, not a problem. An article was published back in 1997, I believe, on outpatient maggot therapy, and that would be the Archives of Physical Therapy and Rehab. How do you remove the maggots from the wound? Manually, ? Well, you could use a suction device, but I recommend simply loosening up the dressings all the way around, having a wet gauze pad by your side, and a red bag or infectious waste bag by your side. Maggots should be disposed of as infectious waste, just like any other wet dressing waste. I then peel back the maggot cage dressing like a banana peel, while I wipe with my other hand and the gauze pad, the wet gauze pad, I wipe it across the wound, sandwiching the maggots between the old dressing and the wet gauze. I then lift up these two dressings and the maggots sandwiched in between and drop them in a red bag. If you are working on an extremity wound, you can lay the extremity over some chucks or over a garbage bag and do your dressing change right there. Any maggots that escape the area will drop into the bag. You wrap up the bag. Then tie off the bag. Don't use rabbit ears. Tie it securely with a knot. Put that in a second bag. Tie that with a knot and throw it with your infectious waste. I see a question here. Is there a distributor of the flap dressing in Australia? This is a Monarch Labs product. There is no distributor, to my knowledge, of the flap in Australia. Monarch Labs does send the flap and other dressing items overseas, though, if requested, and you should contact Monarch Lab. There is a listing of Maggot distributors, as one person has asked. Go to the Better Foundation website, to the Maggot Therapy page, and scroll down or use the link at the top of that page for medicinal maggot distributors. I see here a question about people doing the legwork, technicians, maggot therapy technicians. There are indeed maggot therapy technicians who have taken our workshop. The physicians merely need to prescribe the treatment, and these individuals are quite capable of doing all the dressings and follow-up. Sometimes a wound care nurse or the clinic nurse will do the dressings. Sometimes patients at home will have their family members or friends do the dressings. But the Better Foundation tries and educates people who are going to do the dressings to anticipate what they're going to find and how to deal with it. Is there a danger of maggots destroying healthy tissue? The maggot's secretions appears to be incapable of dissolving healthy tissue. That's great news. I mean, it allows us to treat wounds that have granulation tissue and necrotic tissue both without having to worry about the healthy tissue while we're trying to debride the necrotic tissue. That said, the drainage, those secretions, plus all the bacteria, plus all of the patient's pus cells and necrotic debris, that's filled with proteolytic enzymes. It's filled with infectious matter that should not sit on the wound for long. And if it does sit on the wound, or the healthy tissue for that matter, you're going to have maceration. And with maceration comes breaks in the skin integrity and problems. So you can see some problems if these wet dressings or if the secretions are allowed to sit under the if they are allowed to sit on the healthy tissue. In addition, if you leave the maggot dressings too long and the maggots are mature and trying to get off, they will pry themselves between the skin and the hydrocolloid pad or whatever you've mounted your dressing with. And that scratching, again, adds a portal through which some of this drainage and the bacteria can enter and cause harm. So you have to be on the lookout for that. We pre-treat the healthy skin around the wound with a skin protectant, a polyurethane plastic protectant, which is available in a wide variety of liquid formulations or swabs or pads. Many people, especially in Europe, use zinc oxide or a similar preparation to prevent those secretions from getting on the healthy skin. Will this be presented again or available on CD? Indeed, I have recorded this presentation. I will try and post it as soon as I can on our website. In addition, we will try and do it more often if you all enjoyed the presentation. Let me see what the results here. So it looks like the presentation did meet most of your needs. I'm glad at least about that. Any specific comments to or issues you can see us improving, by all means let us know, and we want to do that. It is exactly 1 hour now since this presentation, so I'm going to close it here. I know I didn't get to everybody's question, but I welcome you all to email me. In fact, we also have a CD. The Better Foundation has a CD with a similar presentation and other educational materials, some videos, some patient brochures that you're welcome to. If you join the Better Foundation, you're able to participate in many of these educational programs and get full return on your membership fees. If you just register without any fees, you can access all sorts of educational support materials at the Better Foundation site. So I urge you all to come on over to the Better Foundation website and take a look at what we have. I've just typed in my email address, so you can send me an email if you have any other questions, concerns, or issues. Thank you all so much for participating and joining me today. We had over 150 participants, and that's really exciting to me. Take care, all of you, and I hope I'll be talking to you in the near future. Bye-bye.